This talk is about common muscle disorders. I will start with a case referred to me by Dr. Oscar Martin. Here goes the first case. 7 years of age with difficulty walking. On exam, when asked to stand from sitting position, he pushes himself up as you are seeing in this frame. So the first question is, the way of getting up of this child can be classified as dash. A. Trendelenburg gait. B. Gover sign. C. Lynch sign. D. Duchenne sign. You can see in this frame that the patient fights gravity with his arms. This maneuver is called Gover sign. So the answer to this question is B. Next question is, which of the following is the most likely diagnosis? A. Duchenne muscular dystrophy. B. Werning-Hoffmann syndrome. C. Spinal muscular dystrophy. D. Myotonic dystrophy. Please take a look at these photographs and drawings. The photos were taken by Duchenne of his first patient with the entity that was later named after him. Notice the marked lordosis, the large gluteal muscles, the calf hypertrophy. These are drawings based on these photographs. So the answer to this question is A. Next question is, which of the following statements is not true regarding Duchenne muscular dystrophy? A. Mental retardation occurs in 20% of the cases. B. Predisposes for malignant hyperthermia. C. Tongue fasciculations are present. D. Prone to cardiomyopathy. Remember that tongue fasciculation is the hallmark of a spinal muscular atrophy, which courses with tongue atrophy, and that in myopathy, the tongue is not atrophic but thick and it does not fasciculate. So the answer to this question is C. Next question. Treatment of Duchenne muscular dystrophy includes all of the following except A. Physical therapy. B. Dexamethasone. C. Diet to avoid excessive weight. D. Occupational therapy. Before you answer this question, keep in mind a medical principle: do no harm. Physical therapy, diet to avoid excessive weight, and occupational therapy cannot hurt. So the answer to this question is B. Now I'd like to introduce another case. The case consisted of an 8-year-old boy. During routine blood work, liver enzymes were elevated. Mother commented on how strong he was and on the size of his calves. Notice the size of the calves in this picture. So the first question is, which of the following will you do? A. Repeat liver enzymes. B. Order nerve conduction. C. Order MRI of the thigh. D. Order CPK. CPK was elevated, so was aldolase and several liver enzymes. This is so because liver enzymes are present in muscle. So the answer to this question is D. Next question is, an EMG was done for this patient. Which of the following are you more likely to find? A. Long duration, large amplitude compound muscle potentials. B. Fasciculations and long duration, large amplitude compound muscle potentials. C. Short duration, small polyphasic potentials. D. All of the above. EMG in cases of muscle disease shows short and small amplitude polyphasic motor unit potentials. So the answer to this question is C. Next question. Genetic testing revealed an abnormal gene at XP21. What is your diagnosis? A. Duchenne muscular dystrophy. B. Becker muscular dystrophy. C. Myotonic muscular dystrophy. D. Thompson muscular dystrophy. Please stop the video and read these comments. Then continue the video. So the answer to this question is B. Next question. Patients with Becker muscular dystrophy are more vulnerable to develop A. Malignant hyperthermia, B. Diabetes, C. Malignant hypertension, D. Liver malignancy. Please stop the video and read these comments. Then continue the video. So the answer to this question is A. Now we will address the pathogenesis of Duchenne and Becker muscular dystrophy. We will address the pathogenesis of DMB and BMD together because the pathological mechanism is the same. They vary in degree of intensity. This is a longitudinal specimen of striated muscles. You can see the striations. The nuclei are in the periphery of the fiber, as you can see here and here. The space between the fibers is the endomysium, present here, 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 and here. Were we to cut at the level of the aqua line, as done here, twist the specimen, we will see a different view of the muscle fiber, the transverse view, as indicated by the arrow. In this specimen, the fibers, as we previously mentioned, are cut transversely. Notice their shape. This one is square with sharp corners. This one is trapezoid with equally sharp corners. Nucleus are present in the periphery, as we previously saw, and as you can see in this frame. The endomysium is straight and thin, as indicated here and here. The perimysium is straight and less thin. This is a cartoon. In it, you can see a transverse cut of a muscle. The muscle is attached to a bone. The letter A, B, and C indicate different connective tissue layers. A corresponds to the layer of connective tissue around the whole muscle. B corresponds to the connective tissue layer around the fascicles. And C to the layer of connective tissue around the muscle fiber. The layer of collagen around the muscle is called epimysium. The layer of collagen around the fascicle is called perimysium. And the layer of connective tissue around the muscle fiber is called endomysium. Were we to cut close to the bone, as indicated here, we would see epimysium, perimysium, and endomysium. These tissues at this stage constitute the tendon. And the most important point I want to make with this figure is that the endomysium of each muscle fiber spans from one tendon to the opposite tendon, and therefore they are fundamental for the transmission of force produced by muscle to the bones. Now let's go back to the transverse cut to again look at the endomysium, but at a very small area which also includes the adjacent muscle fiber region, which I have here enlarged and represented as a cartoon in this new frame. And in this frame, I have further enlarged the cartoonish representation of the area visualized. I have done so to label some important structures. Here, I am indicating the extracellular matrix made of collagen 4. Here, the basal lamina, made primarily by protein extensions towards the extracellular matrix and some collagen. The term basal membrane is used by some authors to combine the basal lamina and the extracellular matrix. The basal membrane of two muscle fibers abutting each other form the endomysium. Below the basal lamina, we have the sarcolemma, which is the muscle fiber membrane. And below, we have the sarcoplasm. In it, we find actin and myosin. They are the main components of myofibrils. We can also see mitochondria and a structure that goes from the actin to the inner surface of the membrane. Now, I'd like to shift your attention to the sarcolemma. In it, we find calcium channels, sarcolemma protein complexes, as you can see here and here. These complexes span from the inner to the outer surface of the membrane. In the basal membrane, we find proteins spanning from the outer membrane surface, where they are attached to the membrane protein complexes, to the extracellular collagen. These complex structures are called anchoring structures. The one I am pointing to now is called alpha-dystrophin glycoprotein complex, which I have now isolated and enlarged to label its components. Alpha-dystrophin glycoprotein, beta-dystrophin glycoprotein, sarcoglycan, sarcospam, glycans, muscle lamina 2, better known as merosin, neuresin, prolactin, agrin, syntrophins, neuronal nitric oxide synthetase. This is a very special component of the alpha-dystrophin glycoprotein complex because it produces vasodilatation to match work, thus controls oxygen supply and free radicals elimination. Another compound is named dystrobrevin, and the last and most important for our discussion is called dystrophin. So we have mentioned all the elements of alpha-dystrophin glycoprotein complex. Now let's look at the other anchoring structure, which is called integrin complex, which I have isolated in this frame and now enlarged. This complex protein is made of integrin alpha 7 and beta 1 and merosin. Why are we talking about anchoring systems and DMD and BMD with the same breath? Because DMB and BMD are due to deficient dystrophin. Deficient dystrophin produces alpha-dystrophin glycoprotein complex dysfunction. So this is a normal muscle. Now I am representing the muscle of a DMD or BMD patient. And as you can see, there is no dystrophin. Hence, as the muscle is used, the alpha-dystrophin glycoprotein complex comes apart, leading to membrane disruption and calcium channel widening. It is the consequence of these alterations that establishes the pathological basis of DMD and BMD. As the result of a bad anchoring system, there will be sarcolemma weakening, cytosolic calcium overload, functional ischemia, and free radical stagnation. How do DMD muscle look like? Under light microscopy, normal muscle stained with H&E has the characteristic we described earlier on. Stained with trichrome, thin strands of collagens are clearly seen. Using dystrophin stain, we see a well-organized reticular pattern. And using laminin stain, the organization is preserved. In patients with DMD, muscle stained with H&E looks different. You can see nucleus that are internalized here and here and here. The endomysium is thick and curved. With trichome stain, DMD specimens reveal thick bands of collagen transversing the specimen. Dystrophin stain in DMD muscle is hardly perceivable. Laminin stain in DMD muscle reveals a poorly organized pattern. So, do DMD and BMD muscles look the same? This is a specimen of DMD with the characteristic we have just mentioned. The white areas in this specimen are artifacts. They are related to the density of the adjacent different structures being cut. One important feature not previously mentioned in patients with DMD is myonecrosis. Myonecrosis represents dead muscle fibers being cleared by macrophage. In this specimen, you can see myonecrosis in multiple places. Here, 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 and here. I have now introduced a specimen of a patient with BMD, that is Becker muscular dystrophy. Muscle fibers lack the sharp edge but are not round as those with DMD. We find some internalization of nuclei here and here. The endomysium is thicker than normal and lack linear quality. We also see inflammatory cells, and in this specimen we can see one area of myonecrosis indicated by the arrow. Hence, Duchenne muscular dystrophy and Becker muscular dystrophy differ in degree. Patients with Duchenne muscular dystrophy have a very high percent of dystrophin missing. The percentage of missing dystrophin in Becker muscular dystrophy is less. What is the etiology of DMD and BMD? As you know, it is a chromosomal problem. The X chromosome has a gene located in the small leg at the level of 21.2. This gene is called dystrophin gene, which is the largest known gene in humans. It is the malfunctioning of this gene that produces DMD and BMD. The malfunction is due to, in the case of DMD, frame shift deletions or nonsense mutations. In case of BMD, to non-frame shift deletions of the same gene. What should you do if you suspect DMD or BMD? If you suspect a dystrophinopathy, whether it is DMD or BMD, which usually the suspicion falls in boys with chronic muscle weakness and high CPK, the first step is to get an MLPA or a CGH gene test. These tests detect a wide variety of mutations. If a mutation in the dystrophin gene is found, the patient has either DMD or BMD. If the MLPA or the CGH tests are negative or inconclusive, then you need to do an exon testing looking specifically at the dystrophin gene. If positive, the patient is affected. If negative, the next step is to do a muscle biopsy. If the biopsy is negative, the patient does not have DMD or BMD. If positive, the patient does have Duchenne muscular dystrophy or Beckett muscular dystrophy. The point that I want to make here is that only a negative muscle biopsy in a patient suspected of having DMD or BMD excludes the diagnosis of these conditions. Now I want to jump to a new case. You are called to see a neonate. You shake mother's hand and she cannot let go of your hand. Please take a few seconds to look at these pictures. Notice the mother's facial appearance and the baby's position. So the first question is, this neonate is dash A, hypotonic, B, hypertonic, C, normal. Please, again, take a look at these photographs. Let's look first at the normal neonate. Notice the angle between the proximal region of the limbs and the trunk. The angles are wide. Also notice, indicated by the smaller green arrow, that the lateral aspect of the thigh is not resting on the bed. Now shift your attention to the hypotonic neonate. Notice that the proximal limb regions are closer to the trunk than in the normal neonate. In the arm, this posture is called jog handle, and in the leg, frog leg position. Also notice that the side of the thigh is resting on the bed. So the answer to this question is A. Next question. Which of the following is or are often present in patients with distal myotonic dystrophy? A. GI symptoms. B. Arrhythmia. C. Gonadal atrophy. D. All of the above. Please stop the video and read these comments. Then continue the video. So the answer to this question is D. The next question is, myotonic dystrophy type 1 is due to dash A. Non-frame shift deletions of DMPK gene at 19q13, B. Frame shift deletion of ZNF9 gene at 3q13-24, C. Expansion of CTG repeats in DMPK gene at 19q13 chromosome, D. Expansion of CCTG repeats in DMPK gene 19q13. Please stop the video and read these comments. Then continue the video. So the answer to this question is C. What else do I need to know about myotonic dystrophy? Myotonic dystrophy type 1 comes in many forms. Patients with DM type 1 present as neonates, children, adults, or may be rather asymptomatic and detected only by chance or during a careful neurological examination. I will, nevertheless, use childhood myotonic dystrophy as the model to conduct the rest of this talk unless otherwise stated. Take a look at this photograph. Notice how thin the patient is. Patients with myotonic dystrophy that present during childhood look to me as if they had been placed in a rack and stretched because the body and the head looks longer than expected. He's thin, as we just mentioned, neck is long, the face is long, his mouth is open, frontal baldness is apparent even at this early age. He's wearing glasses. Patients with myotonic dystrophy often have cataracts. The affected gene is 19 at the Q13 site. The gene abnormality has to do with the number of CTG repeats. A normal person has from 5 to 38 repeats. Patients with a bit larger expansion, that is, more repeats, may show only mild symptoms, as the mother described in this case, that lived all her life thinking that everything was well, and it was not until I shook her hand that the diagnosis of myotonic dystrophy was considered and later on made. Patients with slight larger expansions tend to start manifesting overt signs of the disease as adults, although if examined at a younger age, myotonia is often evident. Some of these patients die of cardiac arrhythmia before they seek attention for their weakness. Patients with larger expansions manifest during childhood, as the patient we are using as a model of DM, and when the expansion is really large and the mother has the myotonic dystrophy gene, myotonic dystrophy presents in the neonatal period or in utero, as it did in the case presented in this vignette. Why the more repeat, the worse the condition? This cartoon represents a neuron. I have removed a segment of the soma to see the nucleus. I have now introduced a microphotograph of a nucleus. The arrow points to the double layer membrane of the nucleus and now to the pores. It is through these pores that nucleocytoplasmatic communication takes place. Normally, the nucleus has a large amount of DNA, therefore it is a DNA-rich environment. RNA, here represented by wiggly red lines once formed in the nucleus, goes towards the pores and, as you can see, goes through it, ultimately reaching the cytoplasm. In myotonic dystrophy, the matrix of the nucleus is rich in RNA because the abnormally long gene constructs very long strands of RNA. These large strands of RNA, when attempting to leave the nucleus, get stuck because of their size and produce a bottleneck effect that leads to accumulation of RNA in the nucleus. This pathophysiological mechanism explains why this condition affects so many systems. Most cells have nucleus, and this RNA abnormality is present and significant in most cells. So why do we call this condition myotonic dystrophy? Because in all myotonic dystrophies, percussion myotonia is a prominent finding. If we hit the thinner region, as indicated here, the muscle remains contracted for a while after the hit. This is called myotonia. Myotonia can also be triggered by more gentle hit, in which case myotonia is limited to a few muscle fibers, as you can see in this frame. Myotonia can also be triggered by percussion outside the hand, as you can see in this photograph. Percussion of the wrist extensors will produce sustained wrist extension, as seen here. But probably what sealed the term myotonic dystrophy for this condition was one EMG finding: the classic myotonic discharge. The classic myotonic discharge, as you can see here, consists of fibrillations initially of large size and later of a small size, initially widely apart and later frequently occurring, but then less frequent again. These discharges produce a sound which resembles the noise made by a bomber plane as they reach their target, drop the bomb, and fly away. In light microscopy, in contrast to normal muscle, patients with myotonic dystrophy 1 or 2 show central nucleus, as you can see here, here, and here, and also here. The endomysium is thicker than normal, and the corner of the cells lack sharpness. Next question. Which of the following is not consistent with a definite diagnosis of inclusion body myositis? A. Finger flexion weakness more than shoulder abduction weakness. B. Knee extension weakness more than hip flexor weakness. C. Elevated CPK more than 15 times upper limits of normal. D. Age over 45 years of age. To diagnose inclusion myositis, we need to fulfill a set of clinical and laboratory elements, which are onset after 45 years of age, duration of weakness for longer than 12 months, CPK lower than expected, less than 50 times normal levels, finger flexion weakness should be more than shoulder abduction weakness, and knee extension weakness should be more than hip flexion weakness. The clinical pathological definition of IBM also has pathological requirements that must be met to establish the definite diagnosis of IBM. They are endomysial infiltration by inflammatory cells, rim vacuoles, and accumulation of protein, amyloid, or accumulation of thick filaments. What about if in a patient that we suspect IBM, the criteria is not met? Can IBM be diagnosed in patients not meeting the full criteria? When this criteria is not met, IBM can be tentatively be diagnosed if the clinical laboratory criteria is met and at least 2 of the pathological elements are present or only one is present, and we find in addition upregulation of major histocompatibility class 1. This element is a protein present in the cell surface that helps the cells recognize T cells. So the answer to this question is C. Next question. Which of the following muscles is most likely affected in patients with inclusion body myositis? A. Hamstring muscles. B. Quadriceps. C. Deltoid. D. Iliopsoas. You can see in this MRI of the thigh increased fat-like signal in the anterior compartment of the thigh, which corresponds to the quadriceps. The posterior compartment, where we find the hamstring, looks rather preserved. This finding is consistent with the diagnosis of IBM. Please stop the video and read the comments in this frame. Continue the video once you have read them. In the next few frames, we will make reference to some of these points. As you can see in this frame, the patient with IBM is only able to partially extend his knee. Remember that one of the clinical criteria for IBM was knee extension weakness, an action carried out by the quadriceps, being more pronounced than hip flexor weakness. In this frame, you can see the significant amount of quadricep atrophy that some of these patients have. In this new frame, you can see asymmetrical finger flexion weakness. Remember that another one of the clinical criteria for this condition is finger flexor weakness more pronounced than shoulder abduction weakness. Light microscopy using H&E stain in muscle specimen of patient with IBM shows endomysial inflammatory infiltrates. Higher magnification show a single muscle fiber with multiple rim vacuoles. In this new frame, you can see a single rim vacuole and now an intranuclear vacuole. Electromicroscopy of the vacuoles show lamellar bodies. Electromicroscopy of the actual muscle fiber shows cluster of filaments. In this frame, I have enlarged the later electromicroscopic specimen so you can better see the cluster of filaments. The origin of these filaments, often referred to as tubulofilaments, is unknown. Some authors believe they are formed from myxovirus nucleocapsid, but the myxovirus, to my knowledge, has never been isolated, while other authors feel that they are thick myofilaments. Finding out what these tubulofilaments are is probably the clue to answering the riddle of IBM. So the answer to this question is B. This case, or a similar one, was presented to me by Dr. David. The photographs are from a similar published case. 30-year-old patient presents to your office with the findings below for further workup. She was told by a dermatologist she had Gottron's papules. Which of the following conditions should you consider first? A. Inclusion body myopathy. B. Polymyositis. C. Dermatomyositis. D. Immune-mediated necrotizing myopathy. The first photograph in this frame is the same hand that I showed you in the question. The enlargements correspond to the areas indicated by the arrows. This enlargement is from another patient. I put it there because in it you can really appreciate the characteristic of Gottron papules, raised but flat. The next photo shows hyperkeratotic nail folds with erosions, another frequent finding in patients with dermatomyositis. And the last photo shows heliotrope rash, which is very characteristic of dermatomyositis. So the answer to this question is C. Next question. Based on the specimen shown, which of the following is the most likely diagnosis? A. Inclusion body myopathy. B. Polymyositis. C. Dermatomyositis. D.
immune-mediated necrotizing myopathy.
In polymyositis, the infiltration by inflammatory cells involves the endomysium, and the infiltrating cells are CD8 positive T cells.
This frame shows two specimens.
The first specimen shows polymyositis.
The second specimen corresponds to dermatomyositis. Notice that in dermatomyositis, the bulk of the infiltration is in the perimysium, and that, as stated in this frame, the cells involved are CD4 positive cells.
So the answer to this question is B.
And the last question is, please take a look at this specimen. What is your diagnosis? A, inclusion body myopathy. B, polymyositis. C, dermatomyositis. D, immune-mediated necrotizing myopathy.
I hope you have chosen the correct answer because of remembering that in dermatomyositis, the perimysium is involved. Hence, the fibers close to the perimysium are most affected. Notice the severity of abnormal fibers close to the perimysium in the perifascicular region, and the relative normal-looking muscle fibers deep in the fascicle. Please stop the video and read these important comments regarding dermatomyositis and polymyositis. So the answer to this question is C. The next question is, a 12-year-old boy with fever, headache, cough, and rhinorrhea for 6 days starts complaining of severe calf pain. He is likely to have A, viral myalgia, B, viral myositis, C, immune-mediated necrotizing myopathy, D, tropical myositis. This question names 4 conditions. The first one and the second one just mentioned will be discussed together. Viral myalgias are very common. We have all experienced them during flu season. Viral myositis, on the other hand, is also due to a viral infection, but it is not too common. The symptoms in viral myalgia precede or accompany other symptoms of the viral syndrome. The symptoms of viral myositis start at the end of the disease or days after other clinical manifestations of the viral disease are gone. Viral myalgias produce diffuse, usually symmetrical muscle pain. Viral myositis produce focal pain. Neither of them are associated with erythema. Viral myalgia occurs with any virus. Viral myositis usually follows influenza, especially influenza B virus, but also influenza A, although less often. But when associated with Sclerotinia, Coxsackie virus B infection is the most frequent agent producing it. The third condition named in this question is immune-mediated necrotizing myopathy. This condition is one of the 4 idiopathic inflammatory myopathies. 3 of them, polymyositis, dermatomyositis, and inclusion body myositis, we have already addressed. We will now say a few words about immune-mediated necrotizing myopathy and how to distinguish it from the other 3. The clinical manifestation of IMNM
consists of progressive symmetrical proximal limb muscle weakness occurring simultaneously with myalgia. Weakness is progressive, and in the course of 9 to 10 months it becomes very severe. The CPK is very high. Once the disease is suspected, blood should be drawn for HMGCR and SRP antibodies. If positive, the diagnosis of IMNM is confirmed. You will find that those positive for HMGCR are likely to have been exposed to a statin, a medication usually taken to lower cholesterol. If positive for SRP, the patient is likely to have had or to have dysphagia and is at risk, that is at high risk for myocarditis. If neither of these antibodies are present, the diagnosis of immune-mediated necrotizing myopathy is diagnosed based on muscle biopsy findings. Patients with IMNM and negative serology are prone to malignancy. Muscle biopsy findings in patients with IMNM consist of the findings shown and listed in this frame: necrotic and regenerating fibers with minimal inflammatory infiltration, increased fiber size variability with necrotic fibers, and regenerating fibers with basophilic cytoplasm. These findings differ from dermatomyositis because in IMNM there is no parafascicular atrophy nor significant perivascular inflammation. IMNM muscle biopsy can be distinguished from polymyositis because in IMNM there is no endomysial infiltrate, and it can be distinguished from inclusion body myopathy because in IMNM there is no rim vacuoles or ragged fibers. The fourth condition mentioned in this question is tropical pyomyositis. This condition is an acute focal intramuscular bacterial infection resulting from hematogenous spread. The most common organism causing this condition is Staphylococcus aureus, followed by group A Streptococci. Both of them are gram-positive organisms. Pyomyositis present with point tenderness and focal erythema and swelling, as you can see in this photograph indicated by the arrows. CT shows fluid collection, sometimes large, as you see in this case. This condition usually occurs in immunosuppressed patients. Hence, it is often seen in patients with HIV, diabetes mellitus, sickle cell disease, and in patients on anti-cancer medications. So the answer to this question is B. Next question: which of these biopsies corresponds to myositis ossificans? The biopsies in this question are from 3 different types of myositis. The first specimen corresponds to muscle cysticercosis. Here you can see the capsule of the cyst, and here the clear content. Muscular cysticercosis may present as a mass, as you can see in this photograph. Other presentations are myalgia and pseudohypertrophic of a specific muscle or muscle regions. How are humans infested?
Humans are infected by eating lettuce or other plants that grow close to the ground, irrigated with human feces-contaminated waters. These waters are contaminated with Cysticercus eggs or proglottis. Or they can also be infected by Cysticercus eggs or proglottis present in their own hands. Once ingested, these organisms reach the intestine, go through the intestine wall to gain entry into the circulation, and then they may reach the brain, where they can produce CNS cysticercosis, or the muscle, where they produce muscular cysticercosis. The second condition listed in this question is trichinosis myositis. This condition occurs due to ingestion of undercooked meat infested with encapsulated Trichinella. The meat may be from wild animals, including deer and bears, but more often from pigs. The ingestion of infected meat produces a stereotypic classic manifestation that coincide with the life cycle of the parasite in the human. Once ingested, the capsule is broken down and the larva, now out of the cyst, mature in the intestine and become adult male and female organisms. They mate, and then the female shed live newborn larvae. It is usually these newborn larvae that penetrate the intestinal wall, causing nausea, vomiting, diarrhea, and abdominal pain. Then the newborn larva goes through the intestinal wall and reaches the circulation. As the larva migrates, a systemic hypersensitivity response occurs, which consists of conjunctival hemorrhage, periorbital edema, splinter hemorrhage, and chemosis. The last phase occurs when the larva invades the skeletal muscle and encapsulates, causing pain and weakness. CVC may show eosinophilia throughout the course of the disease, but more so later in the course of it than at the beginning. Muscle biopsy in patients with muscular trichinellosis, as you can see in this specimen, is very characteristic. Notice the encapsulated larva compressing on the surrounding muscle fibers. I have introduced this new biopsy to show you the larva just invading the muscle prior to cystic formation, and here you can see the cyst without the parasite. I will now present a few photographs depicting the most salient features we mentioned when talking about the Trichinella life cycle. Periorbital edema, conjunctival edema or hemorrhage, subungual hemorrhages, skin rash, and eosinophilia. The third condition listed in this question is myositis ossificans. This condition presents as a painful, tender, enlarging mass, usually in a large muscle of the extremities, often the quadriceps. Myositis ossificans usually occurs following a local trauma, leading to an intramuscular hematoma, although a definite traumatic event is not always recalled. Myositis ossificans is essentially a metaplasia of the intramuscular connective tissue resulting in extraosseous bone formation without inflammation, as you can see in this muscle biopsy. An X-ray approximately 3 weeks after the injury is usually required to confirm the diagnosis. The ectopic bone, as you see in this frame, is readily seen. So the answer to this question is C. Thank you very much for your attention.